Thank you for joining us for the American Association of Kidney Patients' 45th Annual National Patient Meeting. I am Kent Bressler. I'm a retired registered nurse with 22 years as an RN with the Veterans Administration and 20 years in the private sector. I proudly served in the United States Army from 1970 to 1972. I have managed kidney disease, specifically FSGS, for over 40 years and received a life-saving kidney transplant from my brother, Kip Bressler, 33 years ago. Monitoring individuals with kidney disease and advocating for preemptive transplantation, which is receiving a kidney before you go on dialysis, is my passion. I'm honored to serve as an AAKP Ambassador for the state of Texas and as a member of the National AAKP Board of Directors. AAKP allows me to brush shoulders with those operating in the kidney space and allows me to give my experience a chance to work for the patients, patient-focused and patient-centered. Today, I am pleased to introduce Dr. Christopher Parker, who will present on disease management, understanding gout and kidney disease. Dr. Parker is Chief of Rheumatology at the Austin Diagnostic Clinic in Austin, Texas. He is active in medical research in his areas of interest, which include gout, rheumatoid arthritis, and inflammatory eye diseases. Dr. Parker is also medical advisor to the Alliance for Gout Awareness, a strategic partner of AAKP. AAKP was a founding member of the Alliance for Gout Awareness in 2018. Since that time, AAKP has partnered on a number of collaborative initiatives to help erase the stigma and misconceptions surrounding gout and increase awareness and provide factual information on the condition of gout, the importance of management, and advancements in treatment options for gout. Kidney patients, through no fault of their own, and like so many other Americans who manage complex chronic diseases, are prone to extremely painful gout for various underlying medical reasons. I myself have experienced gout, and I understand the implications this condition can have on an individual, both personally and in their ability to work or maintain employment. It is now my pleasure to welcome Dr. Parker.
Well, thank you, AAKP, for having me participate in this program on gout, and I'm highlighting its relationship with the kidneys. We're going to be able to really have a lot of fun talking about this topic. I'm going to give you a lot of background on what gout is, how it occurs, and then everybody has a lot of interest in management, so we're going to spend quite a bit of time on that. So before I get into the slide deck on gout, I will say that I've got a patient and I were the co-founders of a support group that ultimately became the Alliance for Gout Awareness. It's a nonprofit organization, and our primary goal, we don't sell anything. Our primary goal is to bring good information to patients who have this illness. We want to empower patients with knowledge to help them really get a hold of their own condition. And when I say good information, let me expand on that for just a second. Because gout has been known about literally for more than 1,000 years, there's all kinds of fairy tale and lore out there about how to fix a gout problem with any number of dietary modifications, and really there's a lot of fairy tale that needs to be dispelled, and that's one of the primary focuses of the Alliance for Gout Awareness. Understanding gout and disease, again, I know everybody out there that's listening has at least some renal insufficiency. I'll give my own background. I'm chief of rheumatology at Austin Diagnostic Clinic. I did my training in the military, rheumatology at Walter Reed, and I did another fellowship in medical research at the National Institutes of Health and the Walter Reed Institute of Research. And I served as a academic rheumatologist for the remaining years of my service obligation. And I came to Austin Diagnostic Clinic in 2003 and have been a community-based rheumatologist ever since. I've always had a special interest in gout, which ultimately got me here. So as I mentioned before, today's program is going to focus on some of the basics and fundamentals on gout, and then we're going to transition to management, which is an area where most people are very interested. If you have gout, you're very interested in how to manage it. So we'll spend the bulk of our time there. I'll definitely be going over the fundamentals of the different medications to be used, as well as a discussion on nutrition. Of course, that's important. And then I'll finish up after that. So here is a couple either or a painting about gout. I include the painting that's a very visual representation of what gout feels like for those people who have not had it. I like this because it really does look like a very painful condition. There's a devil of sorts who's biting into somebody sick and swollen and red. Oh, this thing hurt like anything. I'll tell you that in the more than 20 years that I've been a rheumatologist, and it's amazing how painful this thing is. It's very much the most painful disorders I deal with. One of the soldiers that I took care of in the Army, this was a foot soldier, an infantryman who's a very tough guy, was having a gout attack. And when he was seeing me, he said, "Doc, let me tell you something. I've been shot before. I've passed a kidney stone. I've taken shrapnel. And that stuff's a Sunday picnic compared to what's going on down here in my foot with this gout attack." And then the bottom right picture is a picture of someone with very severe gout with these big nodules and knobs that could be confused with some other kind of arthritis like rheumatoid arthritis. But in fact, this is all gout and then wear and tear on top of it. I like to show it just so people can understand that it can be a very severe and destructive disorder, meaning permanently destroy joints. If it's not managed over time, it'll just build up and get worse. So gout is often referred to as the disease of kings and the king of diseases. And the reason for that is, for a long time it was thought, and this is not true, but it was thought that it could only occur in people who were of royalty, kings. And that's why there's a picture of one of our royalty in the United States, Thomas Jefferson. There's lots of kings in history that have had it. Benjamin Franklin also had gout, but for sure, and here's the actual truth, anybody can get gout. Anybody can get gout. You don't have to have rich food and rich drink to get it. Again, anybody can get it. Your organization, certainly anybody with kidney disease can get it. Well, why in a minute. And then king of diseases, the reason it's referred to as that is just because of the severe pain that it causes. It's king in terms of how much pain it can generate when it really flares up. So what are the risk factors to getting gout? Right at the top, as I mentioned before, is kidney disease. And the reason for that is our kidneys are in charge of lots of things. So it's in charge of all kinds of salts and elimination of waste products and fluid balance and acid-base balance. And if those very important organs are sick, then the downstream problem can be buildup of a variety of waste products, including uric acid. And uric acid is a normal waste product. All of the animals on the earth make uric acid because we eat food, and that's one of the down products. Again, it's a waste product. And so if our kidneys are sick, that waste product can build up, can deposit in and around joints, causing the condition that we know as gout. The reason diet is a risk factor is because there are certain foods that are very high in purines. Think of it like a type of protein. And when that purine is broken down, the end product of that is uric acid. Again, it's up to the kidneys at that point to eliminate that uric acid from the body. But if the kidneys are sick, as I mentioned before, it'll build up. Obesity is another risk factor, not just because they're eating a lot, it's because there's other problems associated with being heavy. And so obesity commonly runs with gout. I want to give you a feel for some others to include things like diabetes, high cholesterol. Family history is a risk factor also. So like in my family, my dad has gout, my little brother has gout. So naturally I need to be concerned and worried that I could develop that, and I keep an eye on it for sure. As we get older, the possibility of having gout increases in kids and men. In men, as we get older, the frequency goes up. And then gender is there because women are protected, because while they're making estrogen, while those ovaries are making estrogen, that has a good effect, and it helps our kidneys excrete that uric acid. But as estrogen levels fall in and around the time of menopause, the uric acid levels rise, and then women can start catching up to men in terms of getting gout. So this is a review as gout ties in to kidney disease and kidney function. I mentioned here the relationship is closely linked. And as our kidney function gets worse, of course, that has its own downstream problems, to include, as I mentioned before, uric acid, a normal waste product, can build up. And so if you looked at a population of people that had chronic kidney disease, literally a full 10th or 1 in 10 of those people will have gout. And I like people to be aware of gout symptoms if they have poor kidney function, so they know what to look for, because I want people who have gout to be diagnosed and managed quickly. And what I tell them is, if you have poor kidney function, you're not all going to get gout happily. But what I want you to look for is a out of the blue, all of the sudden, toe or midfoot or ankle or knee pain. And as I mentioned before, it can be very painful. Like, man, I went to bed last night, I didn't have any problem with my foot or knee. I wake up in the morning and I feel like I broke it and it's swollen and red. I want you to think about the possibility this is gout. And even if you go to the emergency room or an urgent care and they look at it and go, oh, that's cellulitis, meaning inflammation of the skin or infection of the skin because it's red, could it be gout? Because again, they can look almost indistinguishable. And I think many doctors have a lot of difficulties recognizing gout when it's not in the big toe. Big toe is the most common joint, that's true. But the exact same situation at the foot or the ankle or the knee, that can give them a head fake and they start worrying about other things. So keep it in mind if you all of a sudden pain and swelling. I get this question all the time because many people think that the best way to look for it is just check the blood. And that's actually not the whole story. People that have any kind of arthritis, whether it's one joint, which is commonly seen in gout, or several joints, which could happen in gout, or less commonly in gout, multiple joints can get sick at the same time. My diagnostic test that I start with for every patient is the history and physical. I want to learn the story about what happened, when it started. Were there any events that you think triggered it? So I work my way through that history and physical, looking for clues, doing detective work, inquiring about somebody's family history. And then after I've examined them and gotten this history, I try to use lab and imaging like X-ray or maybe even MRI to really firm up my suspicions that this either is or is not gout. And until I'm really confident, I try to really not implement a therapeutic strategy until I really know what's going on. If there's uncertainty, in spite of laboratory studies and imaging studies like X-ray, if it's a primary care provider or some other specialist, I tell people that's why we have rheumatologists. We're the experts here. So if you need help, please refer. If the rheumatologist is the one doing the evaluation and there's uncertainty, the gold standard in terms of making a diagnosis is putting a needle in the affected joint and pulling some of that fluid out and looking at that fluid under the microscope for those for the gout. And I'm going to say gout crystals because they are little crystals, actually crystals. They have optics like any crystal. And so if I see those under the microscope, then I know for sure this person has gout. This picture is what gout looks like. This person has an accumulation under the skin, and there was a cut place there. You can squeeze out this white chalky material. In this person's case, because they had so much gout, that's what it looks like just with the naked eye. But most of the time, you can't see it with the naked eye. They don't have that much, and so you have to look under the microscope. Now, just so you know, don't get worried. Most of the time, I do not need to put a needle in somebody's sick joint. Nobody signs up for that. They don't want that. The only reason I would do that is if I really didn't know and I needed to know. These gout crystals look like under the microscope, since you mentioned it, Dr. Parker. And here is what they look like on the left-hand side of this slide. What I've done here is made a magenta bound so that you could see these gout crystals easier. And many of my patients, when I tell them that they look like little needles, and they really do, as you can see here, they look like needles and they're all over the place in this person's joint that I pulled the fluid out and look at under the microscope here. The reason they are blue or yellow appearing is because I have a shining light through it, through the slide, and then I'm changing some of the optics of the lenses that I'm looking through in the microscope so that it jumps right out, making it easier to see. If you weren't doing changing the lenses around to make it jump right out, they look clear. And then on the right-hand side is the other main thing that doctors have to worry about when someone has a sick, swollen red joint, and that is this thing infected? So on the right-hand side is a bunch of white blood cells, and in the white cells, if you look really closely, you can see these red circles, but there's some even smaller red circles in the middle white blood cell. There looks like little red dots. Those are actually bacteria. And so I tell doctors that the main two things you have to decide on when you have a sick, swollen red joint is it infected or is it gout? Almost never is it both. And if you don't know, you cannot afford to be wrong. Stick a needle in there, pull the fluid out, and look under the microscope. You don't have to guess. Because on one hand, someone needs gout therapy. On the other hand, they need antibiotics. So here, as I mentioned before, a firm diagnosis is very valuable because once you have that firm diagnosis, now you can move to therapy. In the middle, you can see a faint little circle with a little needle right through it. So that's what gout looks like under the microscope without changing the lenses and the background around. They just look like little clear needles. And the circle is a white blood cell. So you can see in this case, the gout crystal is a little bigger the size of a single white blood cell. On the far right, I have changed the background a little bit to make it a little more obvious to see. That's the size, about the size of a white blood cell. So with that, once you have a firm diagnosis, then I want to move to therapy. And here's a picture or a rendition of what somebody feels like when they have those uric acid crystals in there. They're not flaring all the time, but those crystals, when there's not a flare going on, they're still there. And they're just putting abnormal wear and stress on those joints. And so they don't feel good. They have this arthritis in there and their pain and stiffness all the time. And then they'll intermittently flare. So it's another cool picture of what it feels like to have gout. So goals of therapy. Some of this is going to be something you could guess. My patients, when they come to see me, or if they come to see any doctor, they want this flare-up to go away as fast as possible. But I'm also looking ahead. So I'm thinking about prevention right out of the gate. And I want to also prevent permanent joint damage. As I mentioned before, those crystals can literally erode through bone, permanently destroy joints. So I definitely want to prevent that. If somebody said, Doc, can those crystals get into my organs? Can they get into my kidneys or my liver or my brain or my heart? And the answer is anything, anywhere where blood is going, these crystals can land and set up shop, and they can literally be in any organ that cause its own damage. So I don't want that to happen. So I'm trying to prevent damage in other joints, other organs too, not just joints. And then naturally, I want to improve the quality of somebody's life. Whether or not going to improve the length of life, there might be some debate there. There is some data out there that says that you can do that, but whether that's true or whether it's not, as long as I'm not shorting your life and making your quality of life better, that is what I'm trying to accomplish for sure. So management basics, let's walk through the different therapies and give you the fundamentals as we go. When you have a horrible pain, naturally you want to get that pain better or gone as soon as possible. So naturally, people are going to take pain medications. And many people, if not most, or if not all, are doing that before they ever see me. If they have medicine at home that helps with pain, they generally take it before they call because it's so painful. And that might, whatever's at home, they'll do. Most people have acetaminophen, which is Tylenol, or an anti-inflammatory like naproxen, which is Aleve, or ibuprofen, which is Motrin or Advil at home. Naturally, people who have kidney problems, though, meaning our group of listeners, want to avoid any medicines that can impair kidney function. So most of the time, they'll avoid the NSAIDs, meaning the Aleve, Advil, Motrin family. Now, those are all pain medicines. On the right-hand side, I have medicines that are anti-inflammatory, whether or not they help with pain. And so here the NSAIDs are again. Those of us with kidney problems who want to avoid naproxen and ibuprofen and aspirin because that can impair kidney function. And oftentimes we'll use medicines like steroids, also known as corticosteroids. The most common example is prednisone. Now, prednisone is not a pain medicine, but it's a very, very powerful anti-inflammatory, way more anti-inflammatory than Aleve or Advil or Motrin. So, and they're not going to hurt your kidneys. So that's another reason why they're commonly used in people with kidney problems. Sometimes they're injected, sometimes they're taken orally, sometimes they're given IV. However you get the steroids in there, they're powerful anti-inflammatories. And then colchicine is another anti-inflammatory medication that works nicely in people that have gout, a few other inflammatory illnesses also. Important to remember, though, colchicine is not an NSAID, not going to harm your kidneys, and it's not a steroid, which is a great advantage in people who also have like diabetes, because steroids increase blood sugar, so sometimes we really don't want to use them. And colchicine is great because it's not a steroid and it's not an NSAID. But if somebody has poor kidney function, it can make it hard to break colchicine down, and more likely to have most common side effect of colchicine, which is loose stool, or diarrhea. So use with care in people who have kidney problems. You dial the dose down is what I tell the doctors, because I don't want someone to have gout and diarrhea. That's not a fun combination. So let's talk about prevention for a minute, because what I just covered is therapeutic strategies to stop a gout attack. And once that horrible flare-up is gone, the next thing I want to think about is prevention, as I mentioned before. So naturally, here at the Alliance for Gout Awareness, we're doing all kinds of education. I focus on that. And there's pamphlets, or go to the website. And as patients get educated, they very commonly want to talk about nutrition and diet. And I have a very practical approach to that. And I'm going to review it even more in just a minute. But it's important to remember that humans are not really designed to pass up good food, meaning food that we like. And so if you try to manage gout with a low purine diet, the one that you might read about on the internet, you are unlikely to be successful for the long term. Sure, you could gear up and get all excited and motivated to turn over a new leaf and have an arduous, difficult diet, but those don't last. And I take care of Olympic athletes, professional athletes. They're very disciplined people, but they fudge their diet like all of us. And I tell my patients all the time, listen, I try to do a good job, but I'm not perfect. And I don't expect you to be perfect. So I do outline a good, healthy diet, but I don't want someone to feel you can manage this thing with diet alone successfully. Everybody fudges it here and there. And guard, alcohol is a drink, not a food. It actually impairs our kidneys' ability to excrete uric acid. So minimizing alcohol can be helpful in controlling uric acid. But again, I don't tell people that they have to be zero, because I think that is setting somebody up for failure, because most people cannot adhere to a zero alcohol plus a very arduous, difficult diet. There might be some, but not very many. Weight loss for people who are heavy can be helpful. Some, if somebody is on medicines for some other reason that increase uric acid levels, I look at the medicine list and see if I could switch those out or stop them completely. Examples include diuretics like chlorothiazide or furosemide. If somebody doesn't need those meds, eliminate them. Aspirin, the one that can increase uric acid levels. So if they really don't need that, I eliminate it. Now, some people do need it. If you have heart disease and your cardiologist says you need an aspirin, then you need to keep it. I don't take it off if you need it. If it's not clearly needed, then I might try to eliminate it. If somebody has a medical problem that I could put them on a medicine to treat that problem, if somebody has high blood pressure and say they're on hydrochlorothiazide, a diuretic, a water pill, then I think, I wonder if I could switch out that water pill for a different medicine called losartan that also it's a blood pressure medicine that also lowers uric acid. That's a 2-for-1. I'm going to do that. And so I'll try to make those kind of switches if I possibly can. If somebody needs a medicine just to lower uric acid, I certainly have those, and I'm going to talk about that next. So this is the slide that really talks about the goal I want to get that uric acid level with medicines, plus as good a nutritional strategy you give me, to less than 6, meaning I want it between 2 and 6. That's the target, and I'm going to do whatever I can to help you get there. On the left-hand side of the slide are medicines that are designed to help your kidneys excrete uric acid. The most commonly used one is called probenecid. It's a twice-a-day drug. In Europe, they have one called sulfapyrazone. We don't have it here, so I never prescribe it. We'll use probenecid, but most people that have a diminished kidney function they don't have success with these medicines. You really need good kidney function to make them work. So I don't use them in that setting. Some people will try to make cherry juice or other citrus fruits or taking vitamin C. The reason cherry juice or citrus fruits may help uric acid a little is it helps the kidneys excrete uric acid. People want to try that. Again, it's not a very powerful strategy, but if you want to implement that along with what medicines, I certainly am okay with it. Lesinurad was a drug that was available in the United States. It was removed from the market not too long ago because there just wasn't a big market. So most patients will use medicines on the right-hand side of the screen. Allopurinol has been around a very long time. It's an excellent product, and the way it works is you don't have to have good kidney function for uric acid, but you do have to have at least adequate function to break that thing down. So the trick on making allopurinol work is adjusting the dose to achieve uric acid less than 6, meaning get it in the target range, but you have to have enough kidney function to break the allopurinol down, otherwise it could cause a very bad rash. Most doctors that prescribe this medicine know this, and so they're very careful with using allopurinol in patients that have diminished kidney function. If they're not comfortable with doing that, again, this is where having a rheumatologist can really be helpful because we do this literally every single day and we're very good at it. Now, another medicine that can be used in this situation, if we can't get allopurinol to do the job, is a medicine called Febusostat. The brand name is Uloric. It's an expensive drug, but it's not a brand name anymore. It's become generic in the last couple of years, and the price is in fact going down, but it's still pricey. So it's a good backup drug. One of the main advantages, it does not require great kidney function. It can be used in patients with mild to moderate renal impairment. That's right out of the package insert. And then there's literature that says it can be used without dosage adjustment, even in patients with severe renal impairment, meaning severe kidney function. If that fails also, meaning your pills are just not working, happily, we have a medicine called Crystals. It's an IV medication, and it's not to be used for forever. I just say it cleans house. So I'll use this IV medication every couple weeks, really get that uric acid completely out of the body over a period of months, but not years, 3 to 6 or 9 months, whatever I need to really clean house, and then on a pill for maintenance. So it's a very great strategy that have a lot of buildup of uric acid to really clean that house and get that out of their system so that the pill, either allopurinol or Febusostat, can be successful. So here is another slide to simplify the pills that are used most commonly. Allopurinol, main advantages, once a day dosing, not expensive, and around for many decades. It's literally pennies. So even if you have no medical insurance at all, it's on the $4 list at Walmart, so cost is not a problem, but you do have to be careful in our population, meaning patients with renal impairment, to adjust it so that when the allopurinol is broken down, it doesn't build up and cause any kind of rash. Again, if your doctor needs help with that, again, we have rheumatologists that are very knowledgeable in this area. If we can't make it work, either because of kidney function issues or the allopurinol just can't get the job done, we have this Febusostat, as I mentioned before. It was previously a brand name product only, but now it's generic, but it has not been generic long enough to really drive the price down. So it's still pretty pricey. It does not require adjustment based on kidney function, and that's really the main advantage of it. As I mentioned before, let me highlight again that if the standard pill therapies don't work, happily, we have this IV medication. At the bottom of the slide, it says Pegalotocase, and then in parentheses, Crystals. That's the IV medicine that I mentioned before. There is no argument anywhere that it's powerful. This stuff is very powerful, and basically, it's an enzyme It's an enzyme, and enzymes just break stuff down in our body. And so you see a picture of a before and after slide in a matter of months, that great big accumulation of the gout. And again, it's in the ring finger here, that white chalky stuff under the skin, that would take years to go away. If I was using pills, I can clean house in months with this thing, and that's the main advantage. I can really clean house quickly, particularly if I can't make the pills work. If the pills are not adequate at controlling the gout, I'll use it temporarily, and then I'll go back to pills for maintenance so it does not come back. Because once the house is clean, I want it to stay clean, meaning I don't want those crystals to build up and start causing gout. I want to just start seeing patients after the house is clean once or twice a year, making sure their gout never comes back. How do you know if the gout is under control? Well, I don't just ask people. I don't want to guess. That's exactly why I do the blood test. I check. There's no way to know if it's under control without checking. Just because you're not having flare-ups does not mean the uric acid is under control. Remember, gout is an intermittent problem. So it could be high and you're just building crystals only to flare up at, sometime down the road when you're not planning on it. And my patients who are willing to get their blood checked to make sure the uric acid stays in the sweet spot between 2 and 6, then I know they're going to stay protected and not have these periodic flare-ups. If you said, Doc, can I do the blood testing at home like diabetics check their blood sugar? The answer is yes. That technology now exists. There are home monitors that you can get and check your labs at home. But I'll say I also want my patients to let me know how they're doing. So I'll periodically check at the lab as well to make sure that the uric acid's under control. The reason there's a picture of the $100 bill with Benjamin Franklin on it is not because they're expensive. They're cheap. You're checking uric acid, the blood is cheap, even with no insurance. In my lab, it's $20. That's no insurance. Most of the time, insurance covers it 100%. The lab checking at home is not expensive either. I think a monitor will cost $50 or $60, and then people buy tests periodically, so it's not super expensive to check at home. But Benjamin Franklin also had gout, and that's why I have the picture on here. So conclusions and wrap up of the whole talk. Here's the couple things that I want you to know. Gout is a common, very painful, and potentially destructive type of arthritis that's caused by an accumulation of a normal waste product in our body called uric acid. And that uric acid very commonly builds up in people who have sick kidneys, because kidney is the most important organ to getting rid of uric acid. These talks and lectures and all the education that we provide at the Alliance for Gout Awareness is ultimately a message of hope, in that you can manage this thing. You can get these horrible attacks to stop and stay away by controlling the uric acid with good nutrition and medicines. Again, the great majority of patients are not going to have success without some help from medications. But if you do that, you're very, very likely to be successful. And one of my patients, Gary Ho is his name, I think sums it up perfectly by this: either you manage gout or it will manage you. Because when you have all of a sudden your priorities change, right? So it will manage you. It is definitely a manageable condition. And people like Gary who do that, and I'm sure he has not had a flare up in 8 or 10 years, because he's so good at keeping an eye on his uric acid levels. And this guy's a foodie. He enjoys any number of kinds of food, and he still is able to enjoy alcohol in moderation and just acts on the data. So I do think there are some questions out there.
Thank you, Dr. Parker, for an excellent presentation. I do have a couple of questions I'd like to ask. The first one is, can you tell us how your interaction with patients, like the kidney patients you have come to know through AAKP, have been impacting your understanding of the practical issues gout patients face when they manage multiple diseases?
Well, sure, I'm happy to comment on that. Patients who have kidney problems often have other problems as well, meaning they're complicated and they oftentimes have a variety of doctors involved in their care. Kidney doctors, of course, they usually have a primary care doctor. Oftentimes they'll have an endocrinologist, and then here I am, a rheumatologist. And so the ultimate thing to understand when patients are complicated is, number one, we all have to work together, right? And so it's important that doctors are sharing the notes between each other, sharing the lab results, and then acting on the data. The other thing I'll say is the more complex somebody is, the more communication is important, but it doesn't mean that you're not going to be successful. People are still successful even when they have kidney transplants. I do that all the time, and they're still very successful as long as we all work together.
And our second question, Dr. Parker, AAKP has been a passionate advocate of innovation in medical treatments. Can you tell us the importance of patients as allies in helping advance new treatments for gout, and why groups like AAKP play a key role in the future of gout medicine?
Patients who are willing to take initiative and put time and energy behind moving the ball forward. I'm kind of a minded guy, and so I think about moving the ball down the field in the positive direction. So patients, critical role at many levels. Number one, they get educated and ask questions. Number two, they become more and more interested in moving the ball forward in terms of research. They might participate in studies on new medications. And that's how the ball is moved forward. Everybody working together, being interested, spending time, money, and effort trying to advance medical technologies. It doesn't happen without knowledgeable, interested, and energetic patients.
Thank you again, Dr. Parker. On behalf of AAKP, we appreciate Dr. Parker for taking the time to share his insights and expertise.